Hello, welcome to the Psychosocial Distress webinar, screening webinar. I'm Lee Davis, Senior Director of Hospital Systems for the Mid-South Division, and I'm very excited to have you all with us today. For this call, it's aimed at helping each of you be more successful in achieving Standard 3.2 of the Continuum of Care Standards as outlined by the Commission on Cancer. We'll be taking questions at the end of the call, so please jot your questions in the Q&A box in the lower right-hand corner of your screen. We have two outstanding speakers today joining us from the Commission on Cancer, the American College of Surgeons. First, it's Nina Miller, and she's the Cancer Liaison Initiatives Manager. Next, we have Vicki Kennedy. Vicki's with the Cancer Support Community, which is an international nonprofit dedicated to providing support, education, and hope to people affected by cancer. Vicki serves as the Vice President of Program Development and Delivery for this outstanding organization. Thank you both for joining us this morning and sharing your expertise. At this time, we'll begin our presentation with Nina Miller.
Thank you so much, Lee. You can go ahead and move that slide. Thanks so much, Lee. I appreciate the invitation to speak with you today. Again, I'm Nina Miller from the American College of Surgeons Commission on Cancer, and I just wanted to start off by giving you a very, very brief overview. I think that most of you on today's call are very familiar with the Commission on Cancer and our standards for accreditation. I assume that most, if not all of you, are working in or representing the American Cancer Society at a cancer committee at an American College of Surgeons Commission on Cancer accredited program. So I know that program staff and American Cancer Society staff are working towards helping to achieve compliance with our accreditation standards. So just wanted to start off with that today. So as you can see here, this is the mission statement of the Commission on Cancer, and we have 104 commissioners. About half of those are fellows of the American College of Surgeons, and the other half are member organizations, one of which is the Cancer Support Community, which is where Vicki, my co-presenter today, is from. And just wanted to say that those then 104 commissioners get together and help to create the standards that we're all going to be talking about today. So one of the things in our mission is improving the survival and quality of life for cancer patients through standard setting. So we have, of those member organizations, we have people representing administration, representing advocacy and patient-based advocacy, representing allied health professionals, clinical professionals, government, registry, and research and education organizations. So if you go to the next slide, we have just listed here today's learning objectives, where we hope to describe the Commission on Cancer's distress screening standard for you in enough detail that it helps you to clarify where we're headed, to recognize the options for methods to use when implementing the standards into practice, to help to identify the process requirements for distress screening, and discuss how we are going to be measuring standard compliance through the survey process in the coming years. Next slide. So the Continuum of Care standards that were put into place in 2012 included 3 processes that you see listed here. And they're fairly very interrelated. So I wanted to just bring you to this slide because I think it's important that you recognize that a patient navigation process is really looking at identification of the underserved communities that are served through the hospital system and identifying any barriers that there are to those individuals receiving care. So through that process, what's going to be identified are resources that patients can use and any gaps in resources that patients would benefit from having should they exist. So an important part of the whole process. Then next is the psychosocial distress screening standard that we'll talk about in level of detail today. And finally, then a survivorship care plan standard that really brings that sort of patient-centeredness to the table, where you're providing information back to that patient about their care plan, about their treatment plan, about their follow-up recommendations as they enter into survivorship. So hopefully you can see, and the programs that you work within are seeing that these continuum of care standards are interrelated. So if you want to go to the next slide, Lee, the psychosocial distress screening standard is listed here, and it is the Cancer Committee developing and implementing a process. And we'll have a couple of examples of process, what we mean by that for you today. And you're integrating and monitoring on-site psychosocial distress screening and referral. And this is a portion of the standard that is often sort of set aside, and you may want to make sure that that's brought to the forefront with your programs that you're working with. So the psychosocial distress screening is defined as a brief method for prospectively identifying and triaging cancer patients who are at risk for illness-related psychosocial complications that can do one of three things: undermine their ability to fully benefit from medical care, the efficiency of the clinical encounter, and satisfaction and or safety. So simply put, really, it's a screening for cancer patients to determine which are at greatest risk for having psychological and or emotional challenges that would interfere with their ability to complete their treatment. I think just really important to underline that sort of triaging and screening piece, because oftentimes that's getting sort of mixed up into the referral piece, both of which are very important. Next slide. So a definition from the National Comprehensive Cancer Network of what distress is, you can read here. It's along a continuum. So the screening tool is really intended to determine where on that continuum the patient may lie in their coping with their cancer diagnosis. So it can range from anyone who's having a common normal feeling of vulnerability that comes along with a diagnosis for most individuals, to one in which it is disabling, such as someone who experiences a diagnosable, really, depression or anxiety, included along the continuum, certainly varying degrees of panic, social isolation, and spiritual crises. So in the next slide, we can see that about 40% of all cancer patients are really estimated to be having a significant level of distress. So this is one way in which you can have really the program sort of determine whether or not their maybe screening tool is working appropriately. Is it really identifying about 40% of the patients who may be experiencing a significant level of distress that requires some kind of an intervention? So again, as we discussed in the last slide, the emotional distress outcomes that you may be trying to move the marble, if you will, are an increasing adherence to treatment, preventing relapse, and increasing successful survivorship, and reducing costs for the medical system. So recent studies have verified that patients are not likely to initiate these conversations with their physicians about distress, and that often physicians defer to the patients and say, well, if they're worried about something or they're distressed about something, they're going to they're going to tell me about it. And what we know is that that's not always the case, and therefore a screening mechanism to really call out the individuals in need of intervention is vitally important. So at the next slide, you see the process requirements that the Commission on Cancer is requiring as programs comply with this standard. The first one being timing of screening. So in the process document that is created by the Cancer Committee, it must list these things in the process requirement. This is verbatim from the standards manual, so it's available to anyone. So patients with cancer are offered screening for distress, a minimum of one time per patient at a pivotal medical visit to be determined by the program. So the Cancer Committee can decide, and the surveyor is going to be looking for at least one pivotal medical visit, a time and place that can be determined and for when the screening be administered. The methodology is choosing a mode of administration, such as a patient questionnaire, a clinician-administered questionnaire, and that also is then determined by the Cancer Committee. So just to further clarify, there's been some recent discussion here at the Commission on Cancer that mailing or phoning to provide this screening is not going to be necessarily recommended, that they really want to see that there's a specific time in which the patient is in the facility and at a medical visit where this screening takes place, so that if someone is identified as having a high level of distress, that assessment process can be put in place right away. So that's actually something that's fairly new. You may want to relay that to the programs that you're working in. So the process requirements include that determination of the timing of screening. And you might ask, when is that? Well, it certainly could be at the start of the first course of treatment. Other suggestions that have been made are at the time of initial diagnosis or at the transitional times, like at the conclusion of chemotherapy or the start of radiation treatment or even at the end of treatment. So whatever that might be, those are certainly some of the suggestions that you'll find in the literature for when the screening can be or should be done. The standard is for it to be delivered at a minimum of one time. Certainly we would look at programs that are screening more than one time as being favorable. And a position statement from the American Psychosocial Oncology Society done jointly with the Association of Oncology Social Work and the Oncology Nursing Society has come out with a position that says distress can occur at multiple time points from a cancer diagnosis onward and may go unrecognized if screening is conducted only one time. So you can hear from that they're recommending that screening be done additional times besides just one. Research shows that the best method of administration is a self-administered questionnaire as opposed to maybe a clinician-administered questionnaire, but either one is fine as far as the Commission on Cancer compliance with the standard is concerned. So on the next slide is the next process requirement, and that is the tool. So the selection of tool is, of course, critical to your process. A standardized tool that's been validated is certainly suggested. It's not required. Whatever tool is used, an important determination will be how it's interpreted. If the tool comes with a recommended clinical cutoff for when the patients should be triaged to the next level of assessment and then referral for services, then the Cancer Committee will need to determine whether they're going to look at that clinical cutoff and decide to follow that clinical cutoff. So there's some decisions that need to be made based on the tool that is decided to be used. If there's not a recommended cutoff, then how will the program determine guidelines for triaging patients to the next appropriate level of service given the screening result? Those things need to be decided by the Cancer Committee as well, and that documented in the Cancer Committee notes. If you move to the next slide, this is the final, there's two more final process requirements, assessment and referral and documentation. In the process requirement of assessment and referral, it is done to identify and examine the psychological, behavioral, and social problems of patients that interfere with their ability to participate fully in their health care and manage their illness and its consequences. So this assessment needs to be done by an oncologist, nurse, and social worker. I think that at least if it's documented that it be done by a healthcare professional, that's fine, the assessment piece. The referral needs to be to the appropriate individual that would provide that level of service, of course. The assessment results would be prescriptive of the needs to link patients to the physical, psychological, social, spiritual, and/or financial support needs that address the challenges that are causing the high levels of distress. So whoever that might be appropriate to refer that patient to is where that referral then needs to go based on a thorough assessment of the patient's psychosocial needs. It's important, and I might just underline this as well, because I think it's also critical to the American Cancer Society's involvement and participation in this standard compliance, is that information be provided to patients who identify a lower level of distress, but maybe are self-empowered to seek their own assistance with information or referral for concrete services or a self-referral to a cancer support community program or other support groups that may be taking place in the healthcare system. So I think that we would look for, as the surveyors are looking at your process, of making sure that there is care that is given to provide a list of resources to a patient, or the American Cancer Society's 24/7 800 number, or some kind of process to make sure that all cancer patients are given a comprehensive list of support services that are available either on-site or in the community that they can then navigate independently. So most programs have some kind of a new patient packet or information folder that will help them to accomplish this. So next slide is the last process requirement, and that's documentation. So the screening, the referral, the provision of care, and follow-up need to be documented in that patient's medical record. Then, of course, the survey application record needs to be completed. In most cancer programs, I think this is done by the Cancer Committee Chair and/or Cancer Tumor Registrar. And then Cancer Committee minutes should be inclusive of all of these processes and decisions that have been made along the way. The next slide just is a little bit of a schematic to make sure that all of these things are followed to identify those cancer patients at greatest risk. The screening does that identification. Then complete assessments of that at-risk group need to be done. That's a subset of the first group. And then thirdly, that intervention with those most vulnerable patients that through an assessment it's decided that there needs to be an intervention plan, and then referral needs to be done to provide that intervention, or at least to offer that intervention to the patient. And then there needs to be follow-up to make sure that there is, compliance with or documentation of non-compliance with the intervention plan. So the next slide, with compliance, the Commission on Cancer Surveyor is going to be looking for the Cancer Committee's development and implementation of that process, as we've talked about this morning, and that the Psychosocial Service representative on the Cancer Committee is really the one that's overseeing this activity and reporting on it to the Cancer Committee annually. So those documentations need to be in place as well. So the two most critical parts of the standard are the development of the internal processes for implementation and the development of the referral network to make sure that there are adequate resources to meet the needs of patients depending on the results of their screening. So programs should be assessing their infrastructure and be aware of both the internal and external resources that are available to assist their patients with distress management. Documentation of processes and evaluation of outcomes relating to the screening and delivery of care are important. And then in summary, if you go to the next slide then, the summary just is that a screening tool is chosen, a delivery method is chosen, and establishment of that threshold or cutoff as to how patients are going to be triaged for further evaluation and care, a distribution plan for distributing resources information to all patients, a documentation of the gaps in resources and how you might determine the options for addressing those gaps, again related to the patient navigation process standard. Then designation of a healthcare team that's available to do full assessment for those that fall above that threshold, and then the assessment, intervention, and follow-up for those patients in need that's documented in their medical record with the care and follow-up. So the Psychosocial Service representative is the one that reports it back to the committee and discusses the screening and care delivery processes with the surveyor at the survey that's done and completed every 3 years. So that's sort of the nuts and bolts of it. I'm going to turn the presentation over to Vicki Kennedy, who's going to talk about the cancer support community's resources and some of the other resources and some information about some of the tools for you. And I'll be available at the end of today's call to help with questions and answers. Thank you.
Great. Thanks, Nina. That was a great overview of the Commission standards. Hi, everyone. I'm Vicki Kennedy. I'm Vice President of Program Development and Delivery for the Cancer Support Community. We are comprised of over 50 affiliates across the U.S., Canada, Japan, and Tel Aviv, a combination of the Cancer Support Community and Gilda's Club worldwide. So I'm thrilled to be here today to talk about really the implementation side of it. I think, Nina did such a fabulous job of, as we know, this new distress screening standard, to many respects, is really transforming care. It is, in my 30 years as an oncology social worker, I really feel it is one of the most transformative events that truly integrates caring for the whole patient, caring for and truly integrating and bringing to the forefront the importance of psychosocial needs and how many of those can become true barriers to patients receiving optimal care. So what I wanted to talk to you a little bit about today is, there's like a science and an art to distress screening, and it's not a perfect there's no one perfect one-size-fits-all for every provider, for every institution. Even within one institution, there may be needs for a very unique approach for how you're implementing this new standard. Through the cancer support community, we are providing now distress screening through many of our brick and mortar affiliates across the country, and we'll be expanding that. We are also working with many hospitals and cancer centers who are licensing our distress screening program and providing extensive education in those sites. So really, screening is what's unlocking the door. In many ways, you've been doing this in a simple way, perhaps, whether you've actually been using a formalized tool over time, or perhaps what screening was in the past was that a physician or a nurse picked up the phone and said, boy, I need you to come and see this patient. There's a patient in crisis, there's a patient who's problematic, there's conflict in this family. There could be a host of reasons, and it's always to some extent been somewhat unpredictable how we identify these folks and then link them into important resources in your institution or out in the community. What we're really concerned about, we know those folks, if you look at kind of a bell curve, the folks at the bottom of that curve who are really doing fine, have good social skills, have good coping, have a strong family unit and resources, those folks tend to do pretty well. They may be having some emotional distress, but basically they do fine. We also, at the other end of the spectrum, know we're going to see those patients who are really dysfunctional or really having tremendous difficulties navigating the treatment experience, coping with the illness, or mobilizing resources. Those folks will come to our attention. What distress screening about is really getting to that whole middle part of the curve of folks who may look pretty good when they come into the clinic, may come and go, and we may not truly know the burden that they are experiencing, or able to connect them with helpful resources either in the community or within our institution to help them get the support they need. Next slide, please. So there are a host of options to use for distress screening, and over the last 2.5 years, I've had multiple conversations and sat in so many conference presentations and webinars that are looking at all the different screening options in oncology. And there are many excellent choices. One of the things as an institution or your cancer committee needs to think about, are we going to do this on paper? Are we going to do it, ideally, would we like to do it electronically? Are we going to use a web-based program? Are we going to have something within our electronic medical record that the patient can access? What is the vehicle by which we think is going to be most efficient and effective in our institution and with our particular population that we serve? There are many out there, some that are free, some that are not free, in which there is a cost. Certainly the NCCN Distress Thermometer with its accompanying problem list is something many sites are using and have been using for some time. The Distress Thermometer is particularly adept at measuring anxiety and certainly helping to identify some of the various problem areas. It is not considered to be a good measure of depression or a risk for depression, but it certainly can help identify some top anxiety areas for patients and families going through treatment. Cancer Support Source is a web-based electronic distress screening program that we here at the Cancer Support Community have developed and implemented and are implementing across the country. It is, again, all web-based. Patients can take it on an iPad in the waiting room. They can also certainly can access it from home if that's suitable and appropriate for that particular clinic setting. It takes about 5 to 8 minutes for the patient to answer a set of questions in which they're asked to score their level of distress on various topics and then what kind of help would they want. I do think it's helpful to engage the patients in identifying what kind of help they want. I've even seen people adding that to the bottom of a distress thermometer and problem list where you could ask the patient, would you like to see a social worker? Would you like to talk to a navigator? In order to engage the patient in being part of the solution. So we as staff aren't kind of running around trying to find resources and identify needs when we really need to be able to sit down and do a further assessment and discussion with the patient and engage them in the solution. Support Screen is also another wonderful web-based program developed by the City of Hope. It has 58 items as a very in-depth distress screening program, and also has the capacity to automate referrals and resource information. There's the POST, the Psycho-Oncology Screening Tool. Polaris is a company that has a distress management module that is in use. And then there are many other psychometric tools out there. So tools that perhaps may be more diagnostic and less around screening. As you heard Dinah mention, it's that screening is about getting that kind of tip of the iceberg, trying to identify folks that may be at risk, that need further assessment. Screening, by and large, is not a diagnostic tool. It just helps us to identify who's at risk. There are a multitude of psychometric tools out there, and perhaps if you're sitting on a cancer committee, you may see some debates going on between psychology, psychiatry, social work, nursing, et cetera, about which tools are most effective. You really have to look at each one and make a decision about what's going to give you the broadest reach, the broadest capture of the multiple domains in which a patient may be distressed and able to have the best screening tool available to you. Ideally, it's nice if you can have some automated reports that are generated out of a screening tool. I know a lot of nurses, navigators, and social workers who are using paper tools have expressed some anxiety and frustration. They end up with a stack of papers at the end of the week or the end of the month, and they still have to go through them. And unless somebody can enter the data, it's hard to get any aggregate data about the broad reach of needs that you're seeing in your clinics. And how can we take that information and then advocate for the need for more social work staff, for example, or the need for a new navigator in a clinic? So this data, while it's important for you in providing care to your patients, it also gives you an opportunity to provide important feedback to your hospital administration, et cetera, to your physicians about the need and the demand in your clinic setting. There are a host of non-validated tools and measures. I've talked to providers and institutions who said, we just kind of decided to make up our own. We knew what questions were important to our population. Certainly you can do that. I think there's a little bit of risk at that, in that, yes, you may be able to check the box that you're doing distress screening, but are you really using a tool that has been validated against standard measures, that has, for example, an established cutoff point, knowing when patients are at greatest risk and necessitating further assessment? So there is a little bit of risk in that. Nevertheless, I commend the Commission for being open to that at this point in time, and I think it does help, again, just to get it going. Let's just get started with distress screening in your center. Next slide, please. So this is just an example. Many of you have seen this probably, a typical distress thermometer problem list. Again, I think, and there's lots in the literature. You can certainly go to NCCN and to their website and look at the distress screening pathway and read a lot of the literature around the distress thermometer and problem list. Again, often it's how it's administered, right? There's where you get the art of this. I was visiting a clinic, a smaller hematology oncology group practice that was implementing this distress screening, and their idea was to, of course, think in terms of, we want you to think about distress screening. In Canada, they call it the 6th vital sign. So like you do, check someone's blood pressure and their weight and their temperature and their heart and their labs or whatever, you've also got this opportunity to do a checkpoint for distress. What I wouldn't recommend is just loading the distress thermometer and having them point to where they are. That doesn't give you information. The problem list is so key to that. And I think, you know, this one clinic I visit, they had an interesting idea. They laminated the thermometer and put it up near where they weighed patients in. Well, I don't know about you, but whenever I go to the doctor's office, one of my least favorite moments and higher levels of distress is at that scale. If you would ask me to point where I was on that thermometer at that point in time, I might indeed come off extremely distressed or highly distressed, yet really that would not be an important measure for how you needed the help I needed from the system at that point in time. But nevertheless, the distress thermometer problem list is widely used. There are pros and cons with every screening tool, of course, but I think it's, if you will, an easy level of entry for starting with distress screening in many sites. Next slide, please. You'll often see, if you do review the literature, they're also revised. This is called an emotion thermometer scale. You can see that on there could be some opportunities there's a large hospital system, I believe, in Florida who has been using this and has found it helpful. The social worker in this particular institution, social work meets with every newly diagnosed patient and family, and she's now integrated the use of this with her patients as part of that initial interview and intake, and then documents that information into the medical record. Next slide. Next slide, please. So as we know, certainly we can be using a lot of paper, but we also, I really have to put a plug in here for thinking about electronic solutions, either solutions that you create within your institution or your organization, or that you look outside. The IT people in your institution should be a critical component of the discussion and the decision-making you have around the implementation of distress screening. As we know, the volume of patients is on a rapid rise. With over 10,000 people a day turning 65, we know that we are going to be inundated in the next really 5 years with a huge influx of new patients. If we continue to use paper in many of our settings, we are going to be sorely ill-prepared to really handle the magnitude of the patients that are coming through and the complexities of the problems and challenges that they may have. Next slide, please. So if it's possible for you to look at a technology solution, and I mentioned several, City of Hope, Support Screen, Polaris Distress Screening, putting in a distress screener within your own electronic medical record system. Those can be an expensive venture, but could be a good investment for you in the long run, even if you want to create your own within your own EMR. But one example is, as I mentioned earlier, Cancer Support Source. This is a validated program. It has either 15 or 25 items, depending on what set of items you would want to include. And it's password protected. It's totally HIPAA compliant. And again, in this type of electronic system, what this does is it generates reports. The patient gets a report, and the clinicians get a report. In that patient report, much to what Nina was mentioning earlier, even those that any level of distress will generate customized information and links to resources, links to local ACS chapters, links to National Patient Advocate Foundation or other organizations across the country that provide education and assistance to patients and families. Local resources, a local support group, a local program could be integrated into the information that the patient receives. And all of this can be integrated into the EMR, and it also generates aggregate reports. We happen to have our program available in English and Spanish, including all of the resource information, and we are in the process of developing a caregiver distress screener. We're validating that this summer. It will be available at the end of the year, as well as a pediatric distress screener direct to children. Again, when you look at any electronic solutions, what you need to be looking for are the abilities to generate reports, to generate automated referrals. So if someone asks that they want to talk to someone and they are a high distress patient, you can automate a referral to a social worker. So I think there are, or a nurse, or a nutritionist, or a chaplain, all of these, and so most of the electronic systems are out there, all have these different kinds of capacity. Again, the challenge is that there's a cost associated with that. And sometimes for institutions that is just not feasible at this point in time. Next slide, please. Next slide. Okay. I'm not really going to go into this, but we actually have a risk for depression subscale, and many of the tools out there also have subscales that can identify a red flag alert for patients that are at risk for depression or high distress. Next slide. And again, when you're looking at electronic solutions, again, there are many different ways that it can work. But again, your EMR can automatically schedule when a patient's need to be screened for distress, so you could identify key points along the continuum of care. The patient can take the survey either online or on-site. A patient report is generated, and then automated referrals for follow-up and assessment are put into place. It's tracked within the EMR and is all kind of neatly tied together. So there are many creative ways, and so I urge you to think about talking to your IT department about those options. Next slide, please. Oftentimes when we look at distress screening across the country, I can't tell you, both Nina and I have been in multiple presentations, and there is a lot of anxiety and fear and exhilaration about this change, but a lot of current concerns about how are we going to be able to do this. We're running into barriers and obstacles in our institution. Next slide, please. So beyond really what you pick as a tool, you need to think in terms of understanding the culture of your institution or a specific clinic. You need to define and engage key stakeholders and get them engaged in this process, and develop a screening program protocol. When are we going to screen? With what? Where are we going to screen? How are we going to do it? Who's going to do the follow-up? And then what? An important key in the parallel process of this is identifying and mobilizing resources. As Nina mentioned, not just resources within your institution. Don't think or don't let your institution tell you you have to meet all the needs of these people you're screening. You have a community of resources out there locally, regionally, and nationally that you need to tap into. Next slide, please. So there are many barriers that can come up, and certainly we've seen, sometimes it comes down to a lack of consensus on what defines distress. So you saw Nina's definition from the NCCN earlier. Have that conversation so you're all looking to measure the same thing. I've certainly had people say that, my institution expects me to create our own tool. Again, you may need to do that because of the expectation, but there are tremendous tools out there that are already validated that people have spent. We at the Cancer Support Community have spent over 4 years in the research, validation, and development of an electronic tool. We have no money to buy a tool or to build one in the EHR. That may be very much the case, and you need to look at a paper solution. And sometimes you really need to think about, how can I really integrate this across my institution, engaging many different departments. Next slide, please. Oh, and of course, was the cancer committee feeling when the person felt like they were the ones really having to push for this and running into challenges along the way. Next slide, Leah. Thank you. Also, there are lots of biases when you look at even electronic things. I've had many a clinician or seniors are not going to like or be able to use computers or iPads. Indeed, we have not found that to be the case. We like to engage patients in that implementation process, and you'd be surprised how many seniors are now used to using check-in kiosks at their doctor's offices, at the pharmacy, et cetera. And then there's often this idea that patients won't like it, that they're somehow going to push back. Indeed, you may run into some patients who really don't understand it. It's all about the script. It's all about engaging the front desk person to not just hand them the iPad and say, oh, well, I think you need to fill this thing out, but to really say to them, we here at the at the St. Mary's Cancer Center are really committed to understanding how you're doing. And we have this brief survey that would really help us be able to help you better navigate the cancer experience. It's all how we explain them to them. And oftentimes people say that, oh, computers seem cold, or I tried it and it didn't work. Next click on the slide, please. We know that, in fact, many patients and many seniors and people of all socioeconomic groups, et cetera, are perfectly capable of being able to be helped, it may perhaps initially, and very comfortable with the impact of computers in our lives. Next slide, please. We also know that sometimes the staff can be a barrier. The physicians say, oh, I don't want anything to delay the clinic. The nurses are concerned, the clinic's running on high steam, and you really don't want things to get into the way or to slow it down. Or the IT department is resistant or overloaded with other projects. Indeed, we can get buy-in from the team. Bring in breakfast, bring in lunch, have meetings, ask them what they need and what they think will help improve efficiency and effectively in the clinic so that it can work. And give it time. You know, when you first start anything new in a system with new processes, it can feel clunky and challenging. But if you can work together as a team and get buy-in from each area of the clinic or of the institution and give it time and refine and recalibrate, you will be successful. Next slide, please. So really, as I kind of wrap up here, you know, as you are now creating a new culture of screening, referral, and follow-up. So we need to address the fears that are associated with the amount of workload that this may generate, the number of referrals, the disruption to the clinic flow, and professional autonomy, or worried about, well, who gets what referrals and how are we going to manage? You need to create scripts, quick guides for support staff, and also develop community resource contact information and keep that up to date. And train people to talk about distress screening, not as another burden for patients and families, but as a wonderful resource because you as an institution care. And you must evaluate, reevaluate, and recalibrate along the way. You may go down one path with a paper tool and feel like you're doing great, and about 6 months reassess and say, guys, this isn't working, we need to look for new options. So I think you can be very proactive in pulling those together. Last slide, please, or last couple slides, I think. So again, perhaps lay this out yourself, your own little assessment of what are your challenges in your institution. What is the obstacle or the challenge you're facing? Is it the staff isn't buying into it, the physician isn't behind you, or you have limited resources? What is your goal? Develop a tactic for how you can tackle that goal, and then work towards results. So you can perhaps lay out your own grid to see what it is the challenges you're having, what goal do you need, and how are you going to address or resolve that goal to get to the results that you're looking for. Next slide. So we've given you kind of an overview of the standard itself, a brief snapshot of some helpful hints and looking at a variety of tools that are available to you. We'd like to open it up for any questions. As you can see at the bottom, I believe the right-hand side of your screen, you can type in a question that you have there. You won't be able to see each other's questions, but we can certainly read the question aloud and answer that among the group. And I'm going to ask Nina to join me back again on the line so that we can maybe have a dialogue as the questions are coming in. So Nina, as we're waiting for the questions, what's been the biggest change you've seen over the last year as you've been working with sites that are trying to get up and running with distress screening?
Thanks, Vicki. Thanks so much for your great presentation, by the way. You know, I think that initially there was a pretty good level of anxiety amongst programs until they really dug into what distress screening is all about. And I think that there's a pretty good general acceptance of just what you mentioned during your presentation, that we've been sort of anecdotally, if you will, screening patients for psychosocial distress for a long time, and this sort of helps us to put some parameters around it to make sure that we're accessing the appropriate patients at the appropriate time with the appropriate level of service. So I think that programs have generally really embraced the gear up for the phase-in of this standard, and that many programs have actually even put it into implementation at this point.
Great, great. I noticed one of the questions I frequently get is, well, when, especially that initial screening, when should we be screening? Should we just be screening on that diagnosis visit? Should we wait till a subsequent visit? And, I've heard many different points of view on that, but I think that certainly by the standard, they just need to be screened initially somewhere along that continuum. Many clinics have said they've decided not to screen at the diagnosis visit because obviously that's overwhelming in and of itself, and that perhaps even at that point, patients aren't really sure of how this experience is going to affect their whole life. They may not know specifically what their needs and concerns are, and indeed they are anxious about the diagnosis and treatment decisions they're facing. So I've had a few sites say they really enjoyed screening they find it most suitable at the second visit perhaps, of the treatment planning visit, or even at the onset of chemotherapy. And then again, the other big question is, when do we rescreen? And you mentioned along those pivotal points, and that can be challenging in a busy clinic, identifying those pivotal points. So we have many sites that have talked about screening at the beginning and end of treatment, maybe at recurrence, maybe at a regular time interval across the continuum of care. So I think there are many different ways that you can do that.
Yeah, I wanted to just I'm sorry.
This is Lee. We have had a couple of questions while y'all have been presenting, and they have been very consistent. One question has been, are y'all going to share the slides that you presented today? And I wanted to I know, Nina, you said that you would be happy to share your slide deck, but Vicki, I wanted to get confirmation that would you be willing to share your slide deck from today's presentation?
Oh, absolutely. Absolutely.
Okay. I can make sure that is provided to everyone that's on the call. And then the call will be, we had another question that will the call be recorded, or the webinar be recorded? And yes, it has been recorded. So we will be providing that recording, and we can share the slide decks from the call today. So that is one question that has come in.
Great. I see another question here. I think this is a great question. The question is from Timothy, and it says, cancer is a stressful diagnosis for most patients I come in contact with. How do we determine whether this patient is in need of a screening and others are just going through a normal set of stress due to facing the cancer and the treatment process? I think that's such a great question, because really the whole purpose of screening is that it does not come down to a clinical decision or an observation that someone appears to be doing fine, so we won't screen them. Screening is meant for everyone, much like you look at screening mammography or, screening colonoscopies. The whole point of this is to screen all patients so that we don't make assumptions about how they're doing, that we don't determine that someone may just be having normal stressors. Normal stressors, indeed, may have very effective solutions. They may benefit from a support group. They may benefit from transportation assistance. They may benefit from just knowing the services that you have available to them. So I think that's a great question, but it really comes down to screening all patients across the continuum of care. And I think, Nina, that can be daunting, particularly in smaller cancer centers that don't have an extensive social work staff or don't have many navigators. The fear is they're gonna uncover so much that they can't meet the needs. Have you noticed that kind of sense?
Yeah, I think that there's a lot of concern about that, and I think that as long as the gaps in resources are identified, it's certainly going to meet with standard compliance. I think that what we're hopeful is that then generates the cancer community, if you will, to be, motivated to, address those gaps in resources so that patients can be served in the way in which they need to be served, whether it's the provision of a navigator or the provision of a transportation system to get people to treatment because it's so difficult, or maybe, submission of a grant to help to pay for certain individuals in certain communities to have, transportation vouchers provided or something like that, or that there is the need for a local counseling agency or community organization that provides emotional support to really figure out that they need to develop some skills around addressing the anxiety that cancer patients so often, experience. So, there is a process, and we realize that it may take time for those individuals to, to gear up for addressing all of those. We're not saying you have to fix all the problems. We're saying use this screening tool to triage patients to an appropriate level of care and support, and through that process, address the needs as best as you can. I wanted to
I noticed, Nina, there was a question for you about how, could you give an example of how to monitor their process? So is it a random chart review and report to the cancer committee? Are there suggestions about how to monitor the processes they put into place?
I think it's not necessarily chart review. I think that it's truly what kind of process is written into the cancer committee minutes. So the whole process needs to be overseen by the psychosocial service representative or coordinator on the cancer committee. That's really the first step in the process. Identify who it is, whether it be an oncology social worker, a nurse, a patient navigator, a psychiatrist, a psychologist, an individual physician, even the person who is identified as a psychosocial service coordinator, and then that person is really in charge of pulling together the process. What's it going to look like? Is it going to be electronic? Is it going to be paper-based? Some of the things that Vicki was really talking about. How are the individual pivotal visits going to have been decided and are going to be put in place? I know that, Vicki, you mentioned something about a program that was looking at the second visit for the patient because the first visit can be so stressful in and of itself. Well, we had a program say, that was really tough for us to figure out. Our receptionist didn't know whether this was their second visit or their third visit, and so they got distressed by virtue of the fact that they couldn't figure out whether they should be giving a screening tool to the patient that arrived that day. So make sure that your process within your clinic or hospital actually is something that you can put into place and have it be something that you can count on. So if you can track that this is the last chemotherapy visit for a patient or the fourth chemotherapy visit for a patient, and that's when the screening tool is put in place, then that's fine. But if it's not possible, your pivotal medical visit may need to be revisited, for example. So I also saw a question in there that what is this meant to really screen all patients or just an identified population. And I would venture to say that, certainly the expectation is that all patients are given a methodology of some kind to be screened. That doesn't mean a social work assessment or a full psychosocial assessment need to be completed on every patient. It's that they were given a screening tool, and that those who appropriately should be triaged for further assessment and intervention is put into place. So it is intended to be for all.
Great. For all, and I think what's interesting is what may work if you work in a site that has multiple clinics. So what may work in your screening protocol for the breast clinic may look very different in a lung clinic or in a radiation oncology. So I think it's about, and I often recommend that you start small. You start in one clinic area, you refine those processes, you learn from it, you develop a really good working system, and then you begin to replicate that throughout your system. And that can be very helpful versus seem a little less overwhelming than trying to implement across an entire system at the same time.
Yep, I absolutely agree.
So, Leah, I think we have covered many of the questions that were provided. We certainly, if questions still come in, I think we can respond privately. And then you mentioned that the slides would be available as well.
That is correct. The slides will be available, and a recording will be provided. So if there are no other questions, then I believe that covers us for today. I want to thank Vicki and Nina for participating with us today and for being our presenters. And thank you all for being on the call and the webinar. We appreciate it.
Great. Thank you.
Thank
you. Bye-bye.